Respected chairperson and dear friends, good afternoon to one and all. At the outset, I would like to congratulate and thank Dr. Calwin for his wonderful organization of this conference, Cardiology Update. My topic is Ischemic severe LV dysfunction, insight on revascularization. The topic is more specific. As we all know, revascularization in the form of coronary artery bypass grafting or PTCA with stenting has proven beyond doubt in acute coronary syndrome in the form of primary PCI. It improves the muscle function as well as survival. Similarly, in chronic coronary syndrome also, in patients having significant anginal symptoms with stenosis of more than 90%, it is proven beyond doubt its beneficial role in relieving the angina. Not only that, it has some beneficial effect on the improvement of survival also. But in patients with low ejection fraction and significant coronary stenosis, the so-called population of ischemic cardiomyopathy, the role of revascularization is the topic for this day. If you take ischemic cardiomyopathy, it's the most important etiological factor for heart failure and accounting for 2/3 of the population. And it has mortality of around 30% over a period of 5 years. Most of the time, ischemic cardiomyopathy patient may present with dyspnea. It may be considered as an anginal equivalent, or it may be a part of the cardiac failure symptoms. The major determinants in the outcome of ischemic cardiomyopathy is the underlying ischemia, so it has to be corrected. So definitely, this is what my hypothesis now. So by correcting this ischemia, by giving the proper revascularization method, we can prevent the recurrent hospitalization and the incidence of malignant arrhythmias, which in turn determine the outcome. So target population for today's talk is ischemic cardiomyopathy. They are defined as ejection fraction less than 40% with the NOHA class 2 or more symptoms, along with the significant diameter of coronary artery stenosis. So currently available modality of therapies include the guideline directed medical therapy, otherwise called as optimal medical therapy, is the backbone for the ischemic cardiomyopathy management, which includes the 4 pillars of the heart failure as we discussed previously: ARNI, SGLT inhibitors, beta blockers and mineralocorticoid receptor antagonists. They are the backbone in the treatment of the ischemic cardiomyopathy. Their benefit has been proven beyond doubt in various randomized clinical trials as well as non-randomized clinical trials. Similarly, device therapy is indicated in selected group of population as discussed by our Dr. Nadarajan sir, like CRT and ICD prevents a sudden cardiac death also in a patients with ischemic cardiomyopathy. This is one of the mode of death in a ischemic cardiomyopathy. But regarding the revascularization, we have 2 modalities: coronary artery bypass grafting and percutaneous coronary intervention. That's a target talk today. To answer this question, I have to going into the pathophysiological insights of the ischemic cardiomyopathy and what type of revascularization, whether CABG versus PCI, finally what is the evidence. If you take the history, coronary artery bypass graft has proven its beneficial role, especially in ischemic cardiomyopathy patients, even before the stenting era, especially during the 1980s by CAS registry. And similarly, there are so many observational studies and non-randomized trials and registry data has proved the beneficial role of coronary artery bypass grafting, giving the revascularization and improving the survival benefit in ischemic cardiomyopathy. But in the current era of evidence-based medicine, the randomized clinical trials does not support the evidence given by the previous studies. Stitch trial and the heart trial, part 2 and ischemia and revive trials does not support the benefit of the coronary artery bypass grafting over medical therapy. This is the statement given by the Stitch trial investigator, which is a landmark trial of ischemic cardiomyopathy patients. We were unable to show significant benefit for a CABG in our primary analysis. Notable point, primary analysis. But if you dive deeper, the data are much superior and supportive for the bypass surgery. Similarly, a meta-analysis done by the Allman et al. During 2002 has demonstrated significant benefit of the revascularization. Here we can see the mortality rate around 6. Here in revascularization group it's only 3.2, almost a relative reduction of 80%. Why this controversy between the observational data, previous studies, but the randomized data? to understand that, we should know some pathophysiological insights about the ischemic cardiomyopathy. So ischemic cardiomyopathy having the three different types of myocardium. One is myocardial scar. Here, because of the prolonged ischemia, there will be a severely reduced coronary flow reserve leading to myocardial necrosis and the replacement of the myocardium fibrosis. So it does not have any available fruitful myocardium for the functional recovery. Here the revascularization may not be beneficial at all. On the other hand, in a patient who is having a hibernating myocardium, here the problem is repetitive episodes of ischemia, which leads to reduced coronary blood flow and flow reserve, ultimately leading to ultrastructural changes, leading on to the reversible down regulation of contractile function because of the some amount of reduction in the metabolic function. But on the other hand, metabolic component is relatively preserved, which can be recovered back by the revascularization measures. The another component is stunning, which is an acute event, especially in the myocardial infarction. So obviously reduced blood flow, if we restore, we can restore the function as well as the metabolic component. But we cannot simply say that, because there is one another component, ventricular remodeling. If you are not doing it as early as possible or appropriately as possible, a prolonged ischemia and heart failure will lead on to the vicious cycle of ventricular remodeling, which result in the structural and functional changes in the remote myocardium also, which become more detrimental for the outcome. So yes, we have targeted our population, targeted our therapy. Then about what is a target myocardium, what we are talking about, that is viable myocardium. How to identify the target myocardium? There are so many modalities are available. Echocardiography is the commonly available measure, but it's least sensitive and specific. And the other things, low dose dopamine stress echo, which is actually less cumbersome procedure. Then available things are the SPECT and PET FDG, which are not routinely available in all the places, and the Muga scan and cardiac MRI, of which in our center we frequently use the cardiac MRI, and often some patients will send for the nuclear scan evaluation also, but dobutamine stress echo very rarely performing in our centers. So regarding the low dose dobutamine echo, we are looking into the contractile reserve of the myocardium. During we have to observe the biphasic response. If there is a biphasic response, people will respond in a better way for the revascularization. It means that initially at low dose there will be increment in the contraction. But at the high dose, that when we are going beyond 20 to 30, there will be a fall in the contractile response. This indicates there is a preserved myocardium inside. Similarly, this is a SPECT scan. Here it's actually thallium and technetium scan, where we are focusing on the redistribution after 24 hours. Redistribution after 24 hours. Anybody who is having the increased tracer uptake after 24 hours redistribution indicate there is a viable myocardium. Here we can see this area, we can focus on this area. This area is an anterior segment in the short axis view. Here there is a reduced uptake in the rest, but it is increased after 24 hours. Here this is one evidence. And regarding the PET scan, here we are looking into the two things. One is the flow, another one is the metabolic component by the way of FDG uptake. If the person is having a normal resting flow, normal FDG uptake with normal wall motion is normal. There is no ischemia. Then the second component, there is a reduced resting flow, blood flow, but there is increased FDG uptake, which indicates metabolically intact and abnormal wall motion. This indicates mismatched defect. That word is most important, mismatched defect. Reduced blood flow but increased uptake indicate that viable myocardium. Similarly, another part, there is normal flow with reduced FDG uptake indicates reverse mismatch defect. That is also indicate viability in a stunning myocardium. But on the other hand, matched defect indicate reduced flow, reduced uptake indicate non-viable myocardium. This is one of the current modality of the choice for the assessment of the viability. Regarding the cardiac MRI, instead of assessing the viable myocardium, we are assessing the fibrosis by the way of a late gadolinium enhancement. The gadolinium get enhanced in, trapped in the fibrotic tissue, which will be evident as a delayed enhancement. The percentage of delayed enhancement in a particular segment indicate the amount of scar. If the scar percentage is significant beyond 50%, it indicates that myocardium is non-rectifiable. So we can assess the contractile reserve also with MRI, but which is not routinely done. So this is one image showing, here we can look at this arrow, there is a myocardium thinning before revascularization. Here we can look at the after revascularization, the myocardial thickness, the black area indicate the myocardial thickness. Here in the 4 chamber view, we can observe in the systolic component, there is a significant improvement in the myocardial thickness compared to this area. This indicates after revascularization, there was a viable myocardium which has improved. The thickness indicates improvement in the function. So this is whatever we were talking about summarized. So PET scan assess the metabolism as well as the blood flow. On the other hand, cardiac MRI assess only the perfusion as well as the non-viable scar. Dopamine stress echo assess the contractile reserve. These are all the indicators of the viability which we were talking about. In a PET scan, mismatch indicates hibernation, viable myocardium. Matched defect, that is reduced flow, reduced metabolic activity indicates scar. Similarly, in SPECT, there is redistribution after 24 hours we are assessing. And like cardiac MR, we are talking about the fibrous tissue. Okay, now we have targeted our myocardium. So viable myocardium which has to be salvaged by revascularization. What are the evidence available? As I discussed previously, coronary artery bypass grafting has its own evidence starting from CAS registry, CAS freedom trial and approach and various trial. But in stitch trial, which during the primary analysis, which has not shown its beneficial role. On the other hand, if you look at the stitch extended study of 10-year outcome showed a significant benefit. The initial period of primary analysis does not show benefit, probably because of the early hazard of CABG or not properly included population, like left main coronary disease has not been included in the stitch trial. These are all the possible reason for the negative outcome in the initial period. So coronary artery bypass grafting as a revascularization modality has proven beneficial role along with the medical therapy in a patient who has a ischemic cardiomyopathy. And selection of the patient is most important, especially severe the disease and more the benefit. Yeah, now here we can see, as the same slide which I put already, there is a significant evidence of favoring the revascularization beyond medical therapy. This is a stitch trial outcome. If you see here, the initial years there is no significant benefit. On the other hand, if you go after the second year, we can see the significant reduction in the event rate. There is a curve is separating here. The orange indicate after the revascularization with the CABG. Here the PVV is also more significant. So coronary artery bypass graft definitely having the beneficial role in a patient's ischemic cardiomyopathy on long term, but early hazards to be a concern. So in such a case, now what about the percutaneous coronary intervention over a coronary artery bypass grafting? Coronary artery bypass grafting is the choice, always in a multi-vessel disease and left main plus triple vessel disease. On the other hand, currently revolution is happening with the PCA techniques with the various modalities like intravascular imaging, OCT, intravascular ultrasound helps to optimize the outcome of the percutaneous coronary intervention, and there is rotablation and orbital atherectomy laser. All these things helps in improving the outcome following percutaneous coronary intervention. Similarly, mechanical supports, as we talking previously, Impella and ECMO also helpful in doing the revascularization using the percutaneous coronary intervention. These things are very much useful in a patient who are not a surgical candidate, especially having high Euroscore and STS in a triple vessel disease and left main disease. On the other hand, in a patient who is having the anatomical complexity less, that means syntax score less than 32, percutaneous coronary intervention is growing on par with coronary artery bypass grafting. So revascularization definitely helpful in the patients with ischemic cardiomyopathy. Depending upon the anatomic complexity and surgical risk, we have to select the appropriate mode of revascularization, either coronary artery bypass grafting or PCA. So this is the algorithmic approach. In a patients with ischemic cardiomyopathy, if they have anginal symptoms, definitely there is indication for revascularization. Then if they are not having any angina, they may present the dyspnea alone, which may be an anginal equivalent or maybe a heart failure symptoms, where we need to go for the evaluation of the viable myocardium. If there is a significant viable myocardium, definitely CABG on top of OMT to improve the prognosis. On the other hand, if you are not able to find some viable myocardium, currently guideline favors just viable myocardium, absence of viable myocardium does not negate the benefit of revascularization. So currently guideline favors even in a non-viable myocardium, depending upon the Euro score and other things, revascularization is favored. Actually ischemic cardiomyopathy is a puzzle, but it's a major ailment for the heart failure. It needs to be addressed. As discussed by Dr. Gosishar and others, 4 pillars of heart failure treatment is the backbone for the management of ischemic cardiomyopathy, along with statins as well as antiplatelet drugs. And ICD and CRT in a selected group of patients definitely improve the mortality benefit and morbidity also. Revascularization, the topic for my, is definitely beneficial, but there is no good RCTs available as of now. And for the viability based assessment, here CABG provide a complete revascularization, but based on the viability, we can selectively do revascularization in a particular territory alone. That actually reduces the hazard of the CABG, but there is no randomized data available. But the point you have to consider is, just because you don't see something doesn't mean it isn't there. The star is always there, it yet to come. Thank you.
Thank you, sir, for your excellent talk on approach and ischemic severe LV systolic dysfunction and revascularization. Now the topic is open for discussion.
Here the senior cardiologists like Dr. Madhavan sir, Kannan sir and Selvaganesh sir and Sajgosh sir are there. They can enlighten something extra benefit of my talk if they can. Thank you, sir.